Good morning, dear students. Are you there? Do you hear me clearly?
Yes.
Good morning.
Glad to hear you. If you wish, you may turn on your webcams, cameras on your smartphones or tablets or anything. How are you these days? Okay. I've sent an invitation to the rest. How many students do we expect at our today's lecture? No, already. Your
I
students.
don't know, maybe 8 or
Oh, just 8. Good,
yes.
good. Okay. So our today's lecture is going to be conducted in the course of your internal medicine, right, course, and it will be focused on one of the forms of ischemic heart disease or cardiac artery disease as myocardial infarction. Okay. Good. Okay, so let me check the how many students are present already. There are about 7. Almost all of invited are present, right? Tell me, please, do you have already started your course in internal medicine this semester? Your practical classes, maybe, or other lectures?
Yes, we did.
What did you start already? The practical class, or classes, or lectures? Hello?
We start everything.
Both of them. Good. And what
Good.
topics have you already discussed with your teachers? What topics? Dear students, are you there? What topics have you already discussed in your practical classes or lectures?
COPD and asthma, and
Ah,
we did also in the lecture about high pressure and stuff like that.
uh-huh. Okay. And you had already a lecture in arterial hypertension before, right?
Yes, yes.
Super, super. Good. Have you already discussed angina pectoris or stenocardia?
No.
Not yet. I see. Okay. I'll do my best to focus today on the topic of myocardial infarction. While if you might get any extra questions, feel free to ask. In about 40 minutes, you'll receive your, well, no, not your, but our feedback form proposition to fill it automatically. And I'd like you to register yourself, okay? in it. Okay?
Okay.
Good. What questions do you have regarding our today's topic at the moment? What specific questions? Did you know that we will have this topic to discuss today or not?
No.
No. Okay. What do you know about myocardial infarction at the moment? Do you have any ideas? What is it? Myocardial infarction. What is infarction? People? What is infarction? Maybe you have already, you definitely have already studied this at the course of pathologic anatomy and pathophysiology and maybe other clinical disciplines except internal medicine. What is infarction? What is it? People, are you there? Give me your feedbacks, please.
It's the obstruction of blood supply to an organ.
Okay, look here. Obstruction, yeah, good idea. Thank you. For instance, for instance, for your answer, obstruction, right, and limitation of blockage of circulation is one of mechanisms. It is main, but only one of mechanisms of disturbance of blood supply and further development of myocardial infarction. But what is myocardial infarction itself? Infarction is a form of necrosis, right? Yes, it is one of forms of necrosis characterized by problems with circulation, right? If we are speaking about myocardial infarction, this necrosis happens in myocardium. What other locations of infarction can you imagine, or maybe you already know? What other locations? Could it be infarction of other location? Could it be infarctions?
Yes. Maybe
Mhm.
in the brain.
And brain, I see. Yeah, we know we name it stroke. Yeah, in English, we name it ischemic stroke. We do not name it as infarction, but stroke. Good. Could any infarctions be located in oral cavity? Could it be infarction of a lip, for example, over some piece of lip, or gums, or tongue?
Yes.
Yes, of course. The mechanism is same. Good. Uh, okay, let me represent some theory for you about myocardial infarction specifically, and then we'll come back to discussion if needed. In our today's lecture, I'm going to use some illustrations made by my colleague from other universities or from other um, what's educational establishments. One moment, let me share the screen. Okay, here it is. Okay. Okay. So, let's start. So, the rather often in everyday life, myocardial infarction is named as heart attack. Um, by heart attack, we understand in our everyday life as there is some problem with heart characterized by pain, right? And maybe some consequences of this. Then, uh, as we have already discussed with you, one of fundamental mechanisms of myocardial infarction is blockage of circulation in one or several myocardial vessels, right? And it is myocardial infarction is one of the forms of cardiac artery diseases, CAD. It's literally points on the main mechanism of its development. Once again, as we have already discussed with you before, there could be several different mechanisms of myocardial infarction, while this occlusion, vessel occlusion, is the main. First of all, the first and most frequent type of myocardial infarction is when this occlusion happens spontaneously and due to ischemia, there is the following developments of this necrosis, right? But while this remains the main cause, there could be other cases, other mechanisms, such as there could be increased demands of myocardium in oxygen, and there could be relative um, insufficiency of blood supply and oxygen supply to the myocardium, and therefore development of myocardial infarction. Let's think with you together when, in what conditions this may happen. Again, the first type of myocardial infarction is specifically referred to occlusion, right? To atherosclerosis or to thrombosis or something like that. What's about the second type, when there is relative insufficiency of blood supply or of oxygen supply? In what condition, in what circumstances this may happen? When there are increased requirements. Heart muscle requires more blood, more oxygen, and present normal or almost normal vessels do not supply enough blood. When it may happen? Dear students, any ideas? They could be physiological conditions. What physiological conditions may predispose to such cases? Does anyone or did anyone perform today's morning exercises already or not? Who has? Raise your hand or turn on your video camera or something like that. Just let me know. Who has made? Oh, great! I see some. Nice. I hope that you feel, well, if you do it regularly and if you do physical training regularly, you feel that during these exercises, your heart starts to beat more frequently. And if you would measure, you would know that it also contracts more, both rapidly and with higher power. This condition, when the demands to the heart in terms of blood supply get increased rapidly and significantly. If you have made just usual everyday exercises without any extra effort, extra power, this is just physiological and usually does not lead to any problem at all. It just trains the hearts and the vessels and the nervous system. It turns on the whole organism and let it get prepared for the day, right? For the daily activity. While if anyone would conduct physical exercises with extra effort, with extra power, this often happens in sportsmen, professional sportsmen, especially those who conduct some marathons or either running or swimming or cycling or anything like that. Or this may also happen in sports games like soccer or American football or basketball and so on, when in these game conditions with competition, sportsmen do their best. They are focused on the result, on the victory, to win. They struggle to win, and in this condition they over strength, over excitate the organism, the whole organism, and the requirements increase rapidly, and this requires more rapid and powerful heart contraction. And in this condition, the requirements of myocardium increase greatly, and this leads to probable relative insufficiency of blood supply if there could be two main conditions. If vessels get occluded, of course, it corresponds to the first type of myocardial infarction, or these vessels become contracted, right? Become thinner. This may happen at the stress or overstressing, distressing condition, when these people are not trained enough, and these increased requirements lead to production of much of epinephrine or adrenaline, and this leads to contraction of vessels, and through these contracted vessels there is not enough blood supply, and in this state, there could be also development of myocardial infarction. As soon as this contraction and this not enough blood supply continues for several minutes, for more than maybe 10 or 20 minutes, it depends on conditions in which this organism persists at that moment. Good. The third type of myocardial infarction is described in association with so-called unexpected cardiac death. It happens sometimes. It's one of the separate type of cardiac artery disease, of ischemic heart disease, and there could be different mechanisms of this corresponding to peculiarities of genetics. It could be even congenitive predisposition to such condition. This may be alleviated by some peculiarities of mitochondrial metabolism, I mean energetic metabolism, or by some anomalies of blood vessels and so on. There could be different exact mechanisms, but we just state that third type of myocardial infarction may happen suddenly, unexpectedly, without any clear, at least, preceding factors, or on the background of physical, mental overstressing, of course. Good. Then they could be also the fourth type of myocardial infarction accompanying the operation, which is maybe described as percutaneous coronary intervention or stent thrombosis. Again, either during the operation or after the operation, by some period, there could be thrombosis of these prosthetic components of the vessel, or there could be residues of damaged vascular wall and following thrombosis. And this also may lead to myocardial infarction. Then, the fifth type of myocardial infarction may accompany cardiac surgery. During this surgical operation, there could be damage of vessels, there could be change of blood supply into the heart, and this also may lead to myocardial infarction. I must say even more. Other types of surgical operations, even orofacial region as well, or even tooth extraction by some conditions may lead to change of not change, but into formation of thrombus and its distribution to the region of internal or the self vessels of the heart, and lead to development of ischemic necrosis, or which is we name as infarction, myocardial infarction in this case. And of course, there could be other types of myocardial infarction. We name them in total as myocardial injury. They could be different mechanisms, even just direct trauma as well. Okay. What's the main clinical manifestations in this case? First of all, the most typical clinical sign is intensive, severe pain in precardiac region. It's substernal chest pain, mostly located left side. It lasts for several minutes, and usually it may even persist for hours later, but it is very stable. It does not finish. It does not. It is not stopping even after using of anti-anginal drugs, as it was in case it would be in case of stenocardia or angina pectoris. A part of this pain, these patients typically represent general weakness, lightheadedness, dizziness, and so on. These weakness and so on, they are conditioned by several mechanisms, like disturbance of circulation in brain region. It's the main cause, because heart with this necrosis region usually tries not to contract so much rapidly and with enough strength, and this leads to decrease of the bloodstream all over the body. But one of the first organs which react on this condition is brain, is nervous system in general, and this may be represented as this dizziness and so on. A part of the location of pain in the precardiac region, such as sharp pain, usually it irradiates to left shoulder or to left side of neck, or sometimes in the jaws, or downside into the abdomen region. And usually this pain is associated with preceding mental stress or physical overload or something like that. And what else? As a part of this pain, this may be also this condition may be also manifested by the feeling of nausea, vomiting. This condition is condition is in turn conducted, right, or precipitated by the several mechanisms. One of it is nervous. In this condition of heart pain, and on the background of preceding sympathetic parts of autonomic nervous system hyperactivation, this may rapidly turn into opposite condition with activation of parasympathetic part of autonomous nervous system, and parasympathetic nervous part of nervous vegetative nervous system in turn is associated with intensification of motility of intestine and so on, and even secretory activity, increase of it, right? And this may be triggered, this may trigger this feeling of nausea for one hand. For other, in this condition of myocardial infarction and heart failure, acute heart failure in this case, you will learn, you will study this condition this semester. Due to decrease of circulation, big circulation, including circulation inside the intestine, this leads to disturbance of their condition and function, and this leads to reciprocal motility, and may cause nausea and vomiting as well. Then, one of next typical clinical manifestations of myocardial infarction is decrease of blood pressure, hypotension. Of course, it's reasonable if heart tries to save itself and does not contract so rapidly and strengthfully as it should be. This leads to decrease of cardiac output and decrease of blood pressure. One of other mechanisms of decrease of blood pressure is again this disproportion of sympathetic and parasympathetic activity of sympathetic and parasympathetic parts of nervous autonomic nervous system. If previously there was sympathetic activation and contraction of vessels and an increase of blood pressure, while in case of this pain and cardiac arrest and so on, parasympathetic dominates, and this is accompanied by weakened vascular wall and dilation of vessels, and therefore disturbance of circulation and hypotension. Good. And as a result of this change or disturbance of peripheral blood circulation, we may observe in these patients paleness. It may start in the field of nasolabial triangle or peripheral regions on the hands or legs, on extremities. You may also, during the physical examination, check the capillary filling speed, and it will be weakened as well. It will be prolonged, right? Good. Then they could be, as a result of this disproportion of sympathetic and parasympathetic components of activities of vegetative nervous system, they could be so cool and clammy skin, or as soon as heart tries to compensate the decreased cardiac output, there could be also tachycardia, and therefore a feeling of palpitation. And of course, the main sign remains chest pain. The main risk factors, the main risk factors for development of myocardial infarction include two groups: modifiable and non-modifiable. Smoking. You have already studied this factor. You generally know, and you probably have studied this in the chapter on the parts of your this semester studies related to chronic bronchitis and chronic obstructive pulmonary disease and bronchial asthma as a risk factor, and it also corresponds to risk factor for cardiovascular diseases in the terms of predisposition to atherosclerosis, to disturbance of vessel reactivity, in terms of disturbance of respiratory function as well, and this corresponds to the state of cardiovascular system and so on. Then diabetes mellitus and its presence and hyperglycemia in turn leads to development of endothelial dysfunction primarily, then to impregnation, therefore it's non-enzymatose reaction of the structures of endothelium with the glucose, and change of the function of vessels and heart itself, for one hand. For another, in conditions of diabetes and continuous prolonged hyperglycemia, typically these patients develop neuropathy. It refers to neural disturbances with nerves, and decrease of sensitivity. Therefore, in patients with diabetes mellitus, myocardial infarction has higher probability to develop and low intensity of the pain feeling itself. And it is dangerous because if this would happen in normal condition of these sensory nerves, patient is aware and he would tell about this and complain on these pains, while if sensitivity is abrupted, is damaged, it is not. It doesn't, right? Then hypertension. In conditions of hypertension, due to prolonged overload of heart muscle, due to prolonged influence of the inner parts of vessels, there is the development of damage of them and compensatory hypertrophy of muscular layer both in heart and in vessels, and this leads to thickening of vascular wall. This leads to hypertrophy of myocardium itself, and this increase the risk of two main mechanisms of myocardial infarction, both decrease of bloodstream through the thickened or through the vessels with thickened walls and damaged inner parts, this endothelium for one hand, and the requirements of increased hypertrophied myocardium get increased, and this may cause relative insufficiency of blood supply and oxygen supply and development of myocardial infarction. These are main mechanisms, and there are much more related to disturbance of clotting mechanism, disturbance of hormonal balance, um, change or maybe development of chronic systemic inflammation, and so on. There are many other mechanisms as well. Then the next modifiable risk factor for myocardial infarction is hyperlipidemia, increased concentration of cholesterol of low and extra low density in the bloodstream, right? This leads to increased probability of development of atherosclerosis, which is development of sclerosis inner parts of the vessel, and therefore occlusion of the vessel with this process, right? Then obesity. Obesity itself leads to increased quantity of cells in the body, right, directly, increased requirements of the body in blood supply and oxygen supply, increased requirements to the heart to contract. So hypertrophy, compensatory, it's normal, it's adaptive mechanism of the heart. And as I have already explained, increased requirements of heart in the blood supply for one hand, and for other, as soon as in this condition of obesity, usually it is combined with both hyperlipidemia and hypertension and even diabetes mellitus of second type. All these together significantly predisposes to development of cardiac artery disease or ischemic heart disease, stenocardia, and finally myocardial infarction. The physical inactivity precipitates almost all the previous risk factors, even smoking. If some person is physically active, I believe at least those who raised their hands when I ask whether they did today's morning exercises, right? So if any person is physically active, probably this person doesn't have inclination to smoke. I believe in this. At least there is lower inclination for one hand. For other, these people not so much related to development of diabetes mellitus as well, because their muscles require more source of energy as glucose is or sugar is, and this mechanism leads to use of circulating glucose instead of accumulation of it, and it stimulates representing receptors to insulin on the muscle and other cells instead of losing them, as it is in diabetes mellitus type 2. Physical activity stimulates normal in turn activity of endocrine part of pancreas, and production of insulin, as opposite to diabetes mellitus type 1, when its problem with its secretion, its production at all. Then physical activity regulates vascular tone and heart output or cardiac output, and by this regulates normal blood pressure, and therefore decrease one of previous risk factors of myocardial infarction. Even more regular, normal, reasonable physical activity involves all the components of the metabolism, both proteins, lipids, and carbohydrates, and minerals, and water, and all the rest. And this, again, normalizes the concentration of cholesterol in blood and decrease the probability of myocardial infarction. Of course, if physical activity leads to consumption probably of all needed sources of energy, and there is no place to make depositions of fat in the body. And what is even more, physical activity trains the heart. It trains the vessels of the heart. It trains the coronary vessels. It trains the whole cardiovascular system and nervous system and so on. And the physically trained persons have a significantly lower risk of development of myocardial infarction, even on the background of already developed atherosclerosis, even if they become fatty or with diabetes and so on. So physical activity is essential in protection against myocardial infarction, and its low level of the physical activity. I mean, this leads to significantly higher risk of development of myocardial infarction. There is a set of non-modifiable risk factors for myocardial infarction, like age. With age, especially men and females in postmenopause period, they are more inclined to get developing myocardial infarction because of disproportion of hormones, because of decreased physical activity, because of accumulation of other different disturbances, pathologic processes, or even diseases in different components of metabolism, or some predisposing diseases, and so on. Gender. In general, males are more predisposed, significantly more than females, while females may also get a higher risk of myocardial infarction at the age of postmenopause period. Then, family history of heart attack is also a risk factor for developing of myocardial infarction, mostly in terms of peculiarities of there are several components, internal and external. Internal correspond to hereditary, genetic predisposition. For example, to metabolism of lipids, cholesterol in turn, or maybe to metabolism of carbohydrates and development of diabetes mellitus, or predisposition to obesity and therefore its development, and so on. Every of modifiable risk factor may be conditioned by congenital, or not congenital, but hereditary factors. For one hand, and external factors include just lifestyle. If parents have healthy lifestyle with proper nutrition, physical activity, regimen of general activity and rest, and at all they conduct healthy lifestyle, the probability of development of myocardial infarction, even if this person is predisposed to it, is significantly lower. While it seems to be non-modifiable, but we could modify it indirectly, right? Good. As for terms of prevention, we have already mentioned some aspects of it. First of all, the main approach to prevention is to identify such a predisposition, high risk group for development of myocardial infarction and reduce anxiety regarding this and in general. Then the peculiarity of dental care is so that sometimes some drugs, some medications which are used in dental care may precipitate the development of some of directly myocardial infarction or indirectly to some development of risk factors. For example, vasoconstriction, which is widely used in dental care, may indirectly predispose to the triggering of this condition of myocardial infarction. That is why the advised preventive or prophylactic approach to use of these vasoconstrictor agents is to conduct the dental treatment mostly at morning and make it with as lower stress as it is possible and anxiety. Then, if some person has already underwent the revascularization procedure, it's a good idea to wait for about a month and a half, or when the 2 months is, until making some dental procedures. Such revascularization procedures include either bypass graft or stent placement or other appropriate approaches. The treatment is primarily at the level, at least, of your care, your dental care, is oriented on maybe prediction or some kind of primary or secondary prophylaxis of the development of this heart attack, of the myocardial infarction, and dentist should carefully, thoroughly should ask question the person regarding possible background angina pectoris, or it is also named stenocardia, or other heart problems before starting dental care itself. And of course, even in this condition, they should be very careful adjusting of analgesia and preventing of overstressing of the person, development of anxiety, and so on. The treatment of myocardial infarction, if this happens, includes giving of oxygen. It could be just opening a window or making the airways free of any occlusions if they could happen any. Second is use nitroglycerin. You should give it to the patient, instructing how to use, so putting under the nail, under the tongue, or sometimes they could be sprays use or some other variants of these medications. And as soon as you give nitroglycerin, maybe in few minutes, it could take even less than 1 minute or up to 5 minutes, pain should disappear. If it doesn't disappear for 10 to 15 minutes, it's more likely myocardial infarction. You may repeat giving nitroglycerin twice more. Of course, if you observe that in some patient there is a background of either myocardial infarction preceding, or some preceding cardiac artery disease, or revascularization procedures, or just other risk factors, and this pain develops, and you give nitroglycerin, and it doesn't help in 5 or 10 or 15 minutes, you'd better suppose development of myocardial infarction, because it might be it. Of course, probably you will not be able to fulfill the whole treatment for this patient, and you'd better call emergency and continue assisting and conducting some emergency care to this patient. The next step in the care is use of acetyl salicylic acid. It's named aspirin, 80 milligrams, and probably you will not have the next drug in your cabinet, in your you will not have this drug. While in general, it's a good idea to use narcotic analgesics in order to decrease the pathologic circle, because in the condition of myocardial infarction due to this very severe pain and increased stressing or overstressing of nervous system of this person, this leads to vasoconstriction. This leads to increase of cardiac contractions, and this worsens the condition, because when heart contracts more rapidly and with power, it requires more oxygen, and in condition of lack of oxygen, this significantly decreases the it alleviates, it predisposes to progression of necrosis. That's why use of analgesics, narcotic analgesics, leads to stoppage of this pathologic circle. The signs of recovery when you conduct this medical aid is returning of the condition of patients to initial level. For example, the decrease or disappearing of pain, restoring of blood pressure, normal color of skin, and so on. He becomes more conscious and so on. And vice versa, if there is a worsening progression of the condition, so pain persists and vital signs are unstable, the breathing and heart beating and so on, there could be loss of consciousness and so on. You should also take in mind that, as I have already told, that persons with diabetes mellitus may have peculiarities of the course of this condition, the peculiarities of even signs of it. They could be subclinical signs, or even no signs at all, but development of myocardial infarction. Then, if persons have underwent the operations regarding their vessels, especially of the heart, you should wait with your dental procedures for prolonged term enough. It maybe last for a month and a half or 2 months and even sometimes more. If there was a recent myocardial infarction, or maybe some any surgery, any surgical operation, this might be reflected on the condition of vessels and may lead to obstruction of them and development of myocardial infarction, and you should also take care about this. Do not limit yourself only by dental aspects. Okay, so thank you for this first part of the lecture. Let's make a short break now. If you have any and we'll continue in 10 minutes with you. Tell me please, do you have any questions at the moment? Have you got any new questions probably?
No, doctor, thank you.
So see you in 10 minutes and we'll continue. Just stay here in the same conference. If you have any questions, feel free to ask. You may write. And for instance, take care about the let me show. Okay, about this invitation, the feedback form. The system has automatically sent this email to you with the link to the feedback form. I'll send it to you to our chat now. Don't forget to fill this form. Okay, I see someone already. Good. Only 3 students have registered. Dear students, don't forget to register for the lecture. The link to feedback form has been sent to your emails, and I also sent it to our chat now. Okay?
Okay.
Okay. Please tell those who haven't registered yet. No questions. Myocardial infarction. So if you have any questions, please fill them into the form or just tell me orally. I'll do my best to answer it immediately. For instance, do you have got already your textbooks in internal medicine?
No,
No? And what textbook have you been advised? What?
no textbook.
No?
No.
Okay, maybe let me see. Maybe if I have at the moment, I'll share them. Some good textbooks. Internal. Okay, if you are interested, if you would be interested, just let me know. I'll advise you some good textbooks. If you afford, of course, you may use, it is present in the internet free of charge, the Harrison's Principle of Internal Medicine. Let me, Harrison's Principles of Medicine. Okay. Principles of Internal Medicine. There is the newest is the 20th edition. Do you see on the screen now?
Yes.
Yes, yes.
Yeah, so it's good because it includes all the variety of different pathologies, not only which are learning with you at our department, but in general. It might be very useful for you because in one book you may read about at least main aspects about everything, about all the aspects. Let us check our today's, for example, topic. What is cardiac heart? Heart, cardiac. Disorders of the cardiovascular system. Approach to the cardiovascular disease, basic biology, epidemiology, diagnosis. See, everything is present. Physical examination. All these might be useful for you. And as you see, you may even download it or just use online, as far as I see at least. And there are disorders of rhythm, of heart failure. Oh, coronary. Here is our today's topic: ischemic heart disease. And here are the acute coronary syndrome and myocardial infarction. Acute coronary syndrome is the condition between tachycardia, which is mostly functional disorder, right? With the minor physical changes or structural changes. Acute coronary syndrome is it may be stated as a pre-infarction condition. It's almost infarction, but still not. It's reversible. Yeah, it is already accompanied by structural changes, but it remains to be reversible. And myocardial infarction is irreversible by itself, because it is total death of cells. In average, for instance, people with developed strong or severe myocardial infarction may lose, just imagine this, about 500 cells, I mean myocardial cells, per second, or per minute, maybe per minute, not per second, per minute. No, per second. Because if we manage to conduct proper medical care in 10 to 15 minutes, it's our aim, yeah, to conduct this, to restore the bloodstream. It was calculated in average that a person lost about 500,000 of cells in this period, up to maybe hundreds of thousands, yeah, maybe not 500,000, but hundreds of thousands. So it's very rapid, yeah. So that's why when you observe such symptoms as pain in precardiac region with irradiation, and it is stable, and you give nitroglycerin, it doesn't help too much. You'd better do your best to call emergency or help to transport this person to the hospital if it is nearby as soon as possible. It's essential for him, because as soon as revascularization would be performed, these cellular deaths might be stopped, and they could be much better chance to recover. And as you see, there are the rest of types of coronary artery disease and hypertensive vascular disease. So I advise you to use this. Let me even make a link and send it to you. Have you got this link? The name of the textbook, Harrison's Principle of Internal Medicine, and direct link to this topic. Okay.
Okay.
A part of this, there are very good. At the moment, I don't have it with me now, but if you request, for example, you may simply answer my request for feedback form filling, and just ask me any question related to the topic or in general to this subject. I'll give you some more advices about good sources, strictly aiming on the students, on dental students, you see, because Harrison's Principles of Internal Medicine, it's a general textbook for any medical student. But there are more, I just don't remember at the moment, but there are more textbooks and other publications which might be useful for you, and they are focused on what dentists should know about different conditions in internal medicine as well, and in general in medicine. And for instance, one more, if you go to, oh, I'm sorry, I didn't represent myself. It seemed to me that we have already got acquainted with you before. I'm sorry. So my name is Alexei Kalmykov. One moment, I forgot to put it in the presentation, and I'm professor of this Department of Internal and Occupational Disease of Kharkiv National Medical University. And if you follow my, let me give you a link, my website. If you follow follow the link, and there is an English version of the website I sent to you. Let me give it more specifically English, or you may use just there is a an option of English language option. I'm looking for collaboration with medical students, regardless of their specialty, in terms of, for one hand, learning of medicine itself for you, right? And I would do my best to represent the medicine in most useful way for you, including your ambitions. And for other hand, I looking forward to have colleagues in my team, my joint team, in turn, in order to get some funds, some resources, not only financial, but also maybe some other types of resources, like maybe material, maybe intellectual, some informational. As you can see, we conduct a set of initiatives, and together with medical students, including dental or general medical, we use both staff and material and technical and informational and financial resources in order to restore the infrastructure of medicine in world and in Ukraine as well. During these projects, we also conduct learning of practical medicine as well. And if in brief, I can represent it for you, we build such a cluster structure when so now we, together with you, are representing academic component of this structure of medical cluster. But in total, we unite private medical clinics, such as hospitals, laboratories, diagnostic centers, and rehabilitation centers, non-private medicine like municipal, departmental, and governmental, non-profit organizations, volunteer and charity funds, and non-governmental organizations, academic structures, as we do with you now, and the Kharkiv National Medical University with educational component and scientific, and some other initiatives, including legal support, or maybe communications, marketing and PR, or maybe IT, information technology support, and so on, all together to conduct proper medical care. And we collaborate with foreign partners all over the world, with funds, foundations, I mean, with medical establishments, hospitals, and so on, with academic structures, universities, communities, and so on, and local communities on the regional, city, village, and other levels. All together help students to learn to study much better, to achieve their not achieve, but master their practical skills and theoretical knowledge and everything, and in real practice. And we involve our partners and members of this team and conduct these activities in such proportion that each of people or each of type of organizations who share this cluster, this medical cluster, deals with everyone with those resources which are which they have in excess quantity, right? For example, students may have more free time, relatively, of course, more free time, and they may work on do something as volunteers, or maybe vice versa. Medical students have higher proficiency, right? Medical professionalism, and they may conduct some medical care or consultations. They may work, they may conduct the activity as experts in medical field and even get paid for this. For example, I pay about starting from $5 per hour up to $200 per hour to medics of different competence levels. Good. So let's continue with our today's topic. I'd like to show you some, let me see, maybe this one. Yes. Some more sophisticated approach to myocardial infarction. And oh, no. I want to show you some examples. Just one moment. Sorry, I confused the presentation. One more. Maybe this one. Yeah, exactly this one. Good. I need your feedback now, whether you hear the sound. Do you hear the sound from the video now?
No, Doctor.
Okay, one moment. Let me think. What can I do now? There should be some option. Some option to send you the sound. Just okay, maybe in settings, audio. Maybe there is not such an option, right, in Google Meet. I see. Okay, I'll comment. I'll show you the video and comment by myself. I have specially prepared this for you. Do you see the video now, right? So this is an example when this man has been playing football or soccer and felt a sharp pain in heart region and some breathlessness. You may see that in this condition, due to higher requirements of the heart, there is relatively insufficient bloodstream and oxygen supply to the vessels of the heart and to the cells themselves. And during this physical effort, physical overload, you may see now there is occlusion of the vessel happens. Now it will happen. Up, you may see. So there is a rupture of the vascular wall, and compensatory in order to cover this rupture, platelets and some even sometimes parts of erythrocytes, but mostly platelets, accumulate in this field, and you may see this man feels this problem again and again. Sorry. Some problem with showing the video. One moment. Am I online with you now? There is some problem with it. One more. I'll reload it. Yeah, and what happens then? Due to disturbance of blood supply, while there is lack of oxygen, by the feedback lab, you may see he feels, yeah, he touches his trunk because of feeling this pain. He feels dizziness, he feels breathlessness, while he continue to force himself to continue play. And but anyway, this is accompanied by accumulation of this blood clotting fragments, and this even more hurts him. You see, he feels even more sharp pain. He touches his shoulder, So there is irradiation of pain into his shoulder,
overloaded with the escalating pain signals coming from his
and
heart.
increasing pain again, and he fails. You see? So that it is so sharp pain that this may even lead to cardiac shock, and shock in turn is accompanied by decrease of blood pressure and decrease of
muscle cells is running low on oxygen.
blood supply to the brain, and
John, what's up? What's the matter?
5 minutes after his
compensatory
heart attack began, John's body is struggling to deal with the crisis.
person is
His brain has triggered a surge of the
lying,
hormone adrenaline
right?
into his bloodstream.
This greenish
This is one of the most
coloration
primitive
represents
and powerful reactions in the
the
human body.
attempt of organism to compensate this condition and excrete, product more epinephrine or adrenaline.
Adrenaline arrives in his heart and soaks into its
And
inner walls.
it stimulates the heart to contract more
The pacemaker
with higher
begins to
power
accelerate.
and more frequently, but it doesn't help
John's heart is
because
racing at
there is
140
problem with
beats per minute,
circulation, and
even
this
faster than
even
when he
may
was running around.
worsen the condition. See?
But now all its efforts are focused on its own starving muscle.
As soon as heart muscle starves for the oxygen, this stimulation
But adrenaline
just
can do
worsens the
nothing
condition.
about the growing
And
plaque,
as you see,
which
this
fills 90% of the
clotting
heart.
continues, and obturation
supply of oxygen
becomes
to his
more
heart
and more
cells is down to a
significant. And here is the
They are forced to
illustration
shut
of
down the function which
dying
absorbs
cells
most of their energy.
due to disturbance of circulation. You
They
may
stop
see
beating.
some of these cells stop to contract, and
leaving the
you
rest
see
of his
even
heart to
such
take up the
a
slack.
region of
John's
discoloration
weakened heart cannot
of the
sustain its
muscle.
beat much longer.
They called the ambulance, and emergency care is conducted now. As you see, the first step in this case is conducting an oxygen to increase its concentration in inspired air and
The flow
to
of blood
make
through John's artery is almost
oxygenation
totally blocked.
of the indirectly, of course, of the
The heart
heart
muscle cells no
muscle.
longer have the energy
You
to
may
hold
see
themselves
the
in one
cell,
piece.
and now
Their
it
thin
becomes to
membranes
die.
are starting to leak.
This is the principle of this ischemic necrosis. These patients should be urgently transported to the hospital.
Just hang on in there.
People or these paramedics or medics
John's injured
who
heart is wearing
conduct the
itself
medical
out.
care
Its beat
do their
is
best to
getting
be in
weaker.
touch with the patient to
The effects are
to
beginning to
evaluate
tell on the rest of
whether
his
he is
body.
conscious. Sometimes
John is
patient may
struggling to
demonstrate
breathe
panic,
because his
as
lungs are
you
filling
may
with
see.
fluid.
And you may see the
As his
discoloration
heart
of
weakens,
nasolabial
backs up in the
triangle.
vessels coming
It
from his
becomes
lungs.
pale or even
The extra
cyanotic.
pressure forces liquid out of his blood into the air sacs.
He
of his
tries
lungs.
to breathe more rapidly and with higher frequency,
The
while
process doesn't stop.
you should,
He could
or
drown in
not
his
you,
own
but
body
these
fluid.
medics should control that
You must keep this
person should breathe through the mask, because there is a higher concentration of oxygen in supplied air.
Bringing in a 45-year-old male, possible MI, ETA 3 minutes, over.
Just hold on, John. We're nearly there. They'll sort
Again,
out.
the friend of this person keeps
The lack of
in touch
oxygen
with
in
him,
John's
control
body is
his
beginning to affect
consciousness.
his brain. He's dizzy and disoriented.
Sometimes they may lose their consciousness. One of important aspects of medical care to such patients is to support them with maximal rest.
Time
You
is
see,
running out
you
for
should
John.
keep them in maximal rest to
His
decrease
starved
the
heart muscle cells are
demands
beginning to burst
of
and die.
blood muscle in the oxygen.
If
So
he's
as
not
you can
treated
see,
within
they
the
are
next 20
transported
minutes,
in
his heart
passive
will be so badly
condition,
damaged
just
it
lying
will never
on
beat
the
normally again.
wheelchairs or whatever.
Collapsed with chest pains playing football. No past history. Bit hypertensive. BP
They
90 over 50,
they
tachycardia
control the
120.
heart beating and electric activity of the
They
heart
said about half an hour ago.
by this, ensuring about the what exactly happens. Now doctors ask whether there are any heart problems in the background, in the history of the patient. You may see that this patient
John
remains
is losing
under
500
constant
heart
control
cells
of
each second,
the electric
and unlike
activity
most
of
cells
the
in his body, they can never be replaced.
muscle, heart muscle. While the death of muscles continues, each second several hundred cells die, and it's of course
So let's give him some TPA.
very
By
important,
measuring the
urgent.
pattern of electricity in John's heart, the ECG locates the dying patch of muscle. Now his only hope is that his blocked artery can be cleared by a clot-busting drug, tissue plasminogen activator, or TPA.
Most useful medication in this case is to use
The TPA must reach the clot before so many heart cells die that his heart stops.
is to
and he
use
dies too.
anticoagulants in this case, which dissolve the thrombus, which dissolve the occlusion and restore the bloodstream. And now you may see that at least partly this occlusion has been compensated, right? And the bloodstream restored.
John's heart muscle has been reconnected just in time.
And in few, if not seconds,
Only
but
500,000
minutes,
cells have been lost. The survivors
a
are starting to
significant
beat once
relief
more. His condition
should
has
develop,
stabilized.
and then it takes several weeks for this person to recover and more significantly come to the healthy condition. The next video I'd like to share with you and to
Coronary angioplasty,
comment
also called as
is the
percutaneous
radical operation,
transluminal
is the radical
or
treatment
balloon
of such
angioplasty,
patients.
is a treatment procedure to restore the blood flow
In order to
or
restore
blocked
the
coronary
blood
arteries
flow
caused due to
in this
clots
condition
or
of
blood clots.
thickened
Most
walls of the
coronary
vessels
angioplasty
and
procedures
decreased
last
blood
between
supply,
30 minutes to
the
3 hours.
angioplastic
Once the patient is admitted, his heart
operations
is monitored
are
and is
performed.
given an intravenous sedative to relax the body. A needle is inserted
As
through
you
the
can
wrist
see,
into
the
radial artery. A guard
this
wire
operation is
then
performed
passed through
through
needle
the
and is guided
vein
to the arterial
and
system up to the heart.
reciprocally,
A flexible
not
catheter
reciprocally, but
is slipped over the wire
together with
and
bloodstream,
threaded up to the heart. This
the
is
probe
monitored
is
using a
all the
continuous
instruments
X-ray
are
imaging
needed.
device called fluoroscope.
Medical supplies
this
are
point, the
inserted
guard wire
into
is
the vessel
removed
of the
and
heart,
the tip of catheter is positioned
and
to enter the
by the
coronary
control
artery. A special dye
of
is
X-ray
injected, which
and
allows the
ultrasound
fluoroscope
and
to
sometimes
take
even
X-ray
even
images of
MRI,
the
magnetic
arterial
resonance imaging.
interiors and help in identifying
They
the
reach
position of
the
clot.
blood vessel
This is
with
called
this occlusion,
angiogram.
and you may see
Once the blockage is
they could
identified,
be
a
different
flexible
options
guard
then.
wire is inserted
They
into the
can
artery
either
vessel,
insert
followed by a balloon-tipped
the
catheter
balloon
over
here,
this wire to position
blow
itself
it
at
in,
the site of the
and
blockage.
enlarge the
Rapid
vessel.
inflation and deflation of the small balloon pushes the
By
vessel
inflation
wall
of this
out,
balloon,
re-establishing
they
the flow of
manage
blood in
to
the artery.
enlarge
After the blocked
the vessel and
is
control whether
reopened,
the
the
bloodstream
deflated balloon
has been
catheter
restored.
is withdrawn from the artery. The
In
same treatment
some
procedure
patients,
is
this is
repeated in the case of
enough,
multiple
and there is no
blockages.
need to do
Most
anything more.
patients may
While
also
in
receive a
elder
coronary
patients,
stent,
it's better
which is a
to
small
insert
tube made
the
of wire
stent,
mesh designed
coronary
to keep
stent,
the artery
into
open
this
once
coronary
it has
artery.
been treated.
Again,
A
the
collapsed
principle is
stent
same.
is placed
Inflate
over the
this
deflated
balloon
catheter
and
as it is
insert
inserted
and
into
remain
position.
the
When the balloon is
stent
inflated,
inside the
stent
vessel
expands
forever.
and locks itself
Sometimes
into
they
place.
may
The deflated
replace
balloon
it
and
with other
catheter
in
are
some
withdrawn, leaving the
years,
stent behind to
but
hold
it
the
may remain
artery
for all
open
their whole
permanently.
life.
Post-treatment, a pressure bandage is applied over the radial artery.
So this is the most
One will
radical
need to lie
approach
down
to
for
restore the
several
bloodstream
hours,
and to
during which
prevent
signs of bleeding or
further
chest pain will be
episodes
monitored. The patient
of myocardial infarction. Okay, are you there, dear students? Okay. Okay, so frankly, this is the main. These are the main aspects I have prepared for the lecture. If you have any questions, feel free to ask.
No questions. Everything is clear.
Okay. Should I give you these links to these presentations? How would you prefer?
If you could send it on email.
Okay, okay. I'll send you all the list, okay? All the list of these presentations I'll prepare and send to you. Tell me please, have you already registered for the lecture? There are only 5 of students registered. What's about the rest? Dear students, are you there?
Yes, we're there. We're here. I don't know about the rest.
Oh my God. Because you see, if they would not register, could you maybe let them know? Because if they're not registered, I would need to refer them as missing the lecture. You have time at the moment to do this. Okay, as soon as we have some one moment. Some more time. I'd like also to share one both presentation and maybe introduction into our topics with you. As far as I know, you have started the internal medicine for first time, right? Or you have already studied before?
No, this semester is the first time.
Okay, okay. So let me give some introduction for you about typical changes in oral cavity accompanying internal diseases. I'll also share by this presentation with you, specially prepared for you. Of course, as soon as oral cavity is a part of gastrointestinal tract primarily, the most significant association is between oral cavity and the rest of gastrointestinal tract. For example, in case of acute gastritis or exacerbation of chronic gastritis, you might observe swallowed and plicated tongue and recurrent tongue after, or maybe some erosions or even ulcers sometimes. In case of hyperacidic gastritis, they could be covering of the tongue with such a hypertrophic layer or of fungiform papillae, and vice versa. As soon as during the embryogenesis, there is a very close connection or relation of oral cavity development and the rest of gastrointestinal tract, and this relation remains for all the life of the person. Those changes which happen inside the mucous membrane of the stomach usually get represented in oral cavity as well. So if there is a hypertrophy, let me come back, if there is a hypertrophy of mucous membrane in stomach, you observe hypertrophy of tongue as well. And if there is hypotrophy and hypoacidic condition in tongue, therefore we observe a hypoacidic or hypertrophic condition on the tongue as well. In case of ulcer disease, typically there are no specific changes in the oral cavity, while as soon as ulcer disease is usually accompanied by normal or increased acidity in the stomach. Typically, this patient represents so-called furrowed tongue. So we covering of the tongue with such a whitish layer. The other example of the furrowed, swallowed tongue. The swallowing of tongue and mucous membrane is also conducted or precipitated by common circulation and innervation and even hormonal supply endocrine of all the parts of intestinal tract. And if inflammatory process is accompanied by swallowing of the mucous membrane of stomach, for example, similar changes we may observe in the oral cavity as well. Here is the similar or same changes with a bigger magnification. There could be also desquamations development in case if this inflammatory disease of gastrointestinal tract persists for prolonged time, for weeks or for months and so on. And vice versa. In case of enteritis, or enterocolitis, as in this case, there could be so significant loss of water or fluid that there could be desquamations and furrowed tongue and some even serostomia in these patients. And you should also be aware that this might be not a long-standing stomatological problem, but it could be a presentation of some pathology located in other regions of the body as well. Villus tongue on the background of desquamations, right, in enterocolitis. Then they could be also changes of the tongue and oral cavity in general, accompanying hepatocholecystitis. As you can see, it becomes yellowish on the background of jaundice, and they could be also continuous erosions and even ulcers of the tongue, accompanying hepatocholecystitis and other conditions. And telangiectasias accompanying cirrhosis or severe hepatitis. In pancreatitis, it's inflammation of pancreas. They could be expressed inflammation even of the tongue, its enlargement, its hyperemia. On the background of oncological pathology or some diseases of GAT accompanied by this bacteriosis, they could be intensification of viral pathology as well, and herpetic presentations. A part of GAT presentations from the side of oral cavity, they could be also changes of them on the background of kidneys pathology. For example, candidosis on the background of chronic renal insufficiency or renal failure may be a consequence of immunity disorders because of disturbance of intoxication, in endogenic intoxication. Then in chronic renal insufficiency or failure, there also could be secondary changes of gastrointestinal tract, and therefore presentations from the side of oral cavity as well. In the chronic glomerulonephritis due to blood loss, due to hematuria, there could be paleness of mucous membranes in general and in oral cavity as well, and of tongue as it is shown here, anemic syndrome. In case of chronic prolonged metabolic disorders such as amyloidosis and accumulation of this protein amyloid inside the tongue, there could be also appropriate changes, and sarcoidosis. In case of cardiovascular diseases, they could be non-specific presentations from side of oral cavity too. On the background of cardiovascular insufficiency or heart failure due to disturbance of circulation and disturbance of restoration of reparation of tissues, they could be erosions and even ulcers, and as on this slide, or they could be on the background of disturbance of circulation and hypertension. They could be bubbles formation on the palate and swelling of lips as well, or cyanotic tinge of them in case of heart failure. On the background of atherosclerosis, there could be vasodilation of vessels on the backside of tongue, and you may also observe this in your patients. Or angiomatosis, Randy-Osler syndrome. It's growth, it's what vascular pathology in this case. On the background of chronic prolonged ischemic heart disease or cardiac artery disease, there could be prolonged ischemia of peripheral tissues and atrophy of the tissues. Erosions and erosive glossitis in patient with ischemic heart disease also corresponds to the prolonged dystrophy and atrophy of the tissues. Okay, so I'll share by English version of this presentation with you. So if you have any questions, feel free to ask me now. Okay? Do you have any?
No, doctor, thank you.
Okay. So thank you for attending. See you soon. I'll send you by email the rest of everything needed. Okay?
Okay, thank you.
Okay, thank you. Have a
Thank
nice day.
Same to you. Thank you.
Recording in progress.